So this is the end of the story of the hemostatic disorders, and we talked about the platelet disorders, the coagulopathy, hemophilia, von Willebrand disease, and this video I'm going to talk about the DIC and thrombosis, the last two topics in this subject. Okay, so let's start with DIC. DIC actually is disseminated intravascular coagulation. D, disseminated; I, intravascular; and C is the for coagulation. What is this DIC? From the name, is a disorder on which widespread activation of coagulation mechanism is usually happening, okay, and associated with shock. Okay, so disseminated goes for the widespread all over the body. We have activation of the C, the coagulation mechanisms. So we have coagulation all around the body. What really happens here, that in normal hemostasis we have a balance between thrombosis and hemorrhage. Each second in your body you have a processes of coagulation, and the other side you have a processes of hemorrhage that co-opposite this coagulation. So in DIC we have alteration in this balance. Okay, we have alteration in this balance, so we have activation of coagulation more than expected, we have a thrombosis more than expected, and on the other side we have a fibrinolysis also more than expected, mediated by the plasmin. The result of the activation of coagulation is the decrease in the coagulatory factors, and not just coagulatory factors, but all the factors that contribute to the coagulatory process will be decreased, because we have a disseminated intravascular coagulation. There are many coagulations that are happening all around the body, so the coagulatory factors are consumed. We have less coagulation factors, we have less fibrinogen, okay, less fibrinogen, we have less platelets, we have less factor 2, 5, 8, okay, and also we have a decrease in anticoagulatory factors, not only the coagulatory factors but also the anticoagulatory factors, because if you remember in the first lecture I told you that we have states of coagulation, then we have to have something that anticoagulate that clot. Okay, so it's a normal physiological process in the body, and that what really happens in the IC. We have a lot of coagulations, we have a widespread coagulation, and on the other hand we have also fibrinolysis, we have anticoagulation processes that are happening. Okay, so we have decrease in antithrombin, protein C, protein S, and the plasminogen, all the factors that contribute to the anticoagulation. Okay, how to diagnose disseminated intravascular coagulation? Actually, the diagnosis is a mix between the clinical features and the lab results. There is no definitive test to tell that this is a DIC. Okay, you have to suspect it clinically. How to suspect it clinically? You may have a shock, you may have a bleeding, okay, shock from thrombosis, a bleeding from decrease in the anticoagulatory factors, protein C, protein S, antithrombin, and the plasminogen. Okay, so we may have sudden bleeding from a simple venipuncture or incisional site, or GI pulmonary hemorrhage. We may have petechiae, we may have ecchymosis, signs of peripheral gangrene. Why do we may have signs of peripheral gangrene? Due to the thrombosis that happens. Okay, so these are the symptoms of the DIC. They are non-specific, but they are good to indicate that we may have a case of disseminated intravascular coagulation, especially if we have a patient with collapse or with peripheral gangrene or the shock, bleeding. Okay, so you have to suspect, and you can confirm this by laboratory studies. We have a decrease in fibrinogen. I told you fibrinogen will be consumed, so will be decreased. The platelets also will be decreased. Okay, we have elevation in prothrombin time, inactivated plasminogen prothrombin, inactivated partial thromboplastin time. Okay, activated partial thromboplastin time. We have increase in D dimer, so D dimer will increase. D dimer will increase. Activated partial thromboplastin time will increase. Prothrombin time will increase. Fibrinogen decrease. Platelets decrease. Coagulatory factors decrease. Anticoagulatory factors decrease. Okay, sometimes we may have slow happening DIC. Okay, so it will be compensated to some degree. Okay, so less clinical symptoms, less laboratory findings in these cases. This is the diagnosis of DIC. Now let's move to the treatment of DIC. Actually, we have a great debate on the treatment of DIC, but in brief, the important point about treatment of DIC, we have to treat the disorders that induce DIC, and I forgot to tell you that the DIC is always a secondary process due to underlying disorder like infections, like trauma, sometimes pregnancy, abruption placenta, okay, intrauterine fetal death, pregnancy, so many diseases, okay, and primary causes may lead to DIC. So the first point treatment is to treat the underlying cause of DIC. Then we have to support the patient by correcting the cases of hypoxia, the poor perfusion that may happen, the acidosis, so hypoxia, poor perfusion, the acidosis, the bleeding, blood loss. You should treat all these things. So treat the condition that underlie the DIC, treat the condition that may be associated with DIC like hypoxia, poor perfusion, acidosis, okay, and replace. In DIC we have decrease in the coagulatory and the anticoagulatory factors. We have to replace blood, we have to replace clotting factors, we have to replace anticoagulatory factors. Okay, so don't forget to replace all these things. And the final thing is to give heparin. Heparin is to treat the thrombotic disease unless we have a dangerous bleeding site. So if we have intracranial hemorrhage, for example, we can't give heparin. Okay, so is to treat thrombotic disease with caution because we have bleeding in DIC. This is all I want to talk about in DIC. Now let's move to the final topic. Finally, the thrombosis. Okay, thrombosis is hereditary predisposed, may be caused by many conditions like deficiency in the anticoagulant proteins. It makes sense. Okay, so if I have a deficiency in the anticoagulant proteins like CS, antithrombin 3, plasminogen, we may have thrombosis. Okay, if we have a mutation that increase procoagulants like prothrombin. Okay, prothrombin is a procoagulant protein that will increase the thrombosis. If we have a mutation that will increase the production of prothrombin, then will we have thrombosis. Okay, or if we have a decrease in the things that protect the body from thrombosis, we have thrombosis like what? Like CS, antithrombin 3, and plasminogen. Okay, actually the deficiency in protein C is most of the times dominant. Okay, in the homogeneous cases which is manifested at neonates, it most recessive. Okay, protein S and antithrombin 3 deficiency is dominant, autosomal dominant. What also can cause thrombosis? Damage to the endothelial cells, what we call homocystinemia, may lead to thrombosis. Factor 5 Leiden. Okay, factor 5 Leiden deficiency is most common hereditary cause of thrombosis. So remember always factor 5 Leiden. Okay, the antiphospholipid antibodies may lead to thrombosis. Don't forget. Okay, deficiency in the anticoagulant factor, increase in the procoagulant factors due to mutation. The factor 5 Leiden, very important, antiphospholipid antibody syndrome. The Damage to the endothelial cells may lead to thrombosis. Okay, neonates with deficiency are vulnerable to thrombosis. Okay, very important. Actually, the most common time to present with thrombosis, neonates and adolescent are the most two age groups to present with this condition. Catheterization, vasculitis, sepsis, pregnancy, embolization, nephrotic syndrome, trauma, infection, surgery, inflammatory bowel disease, oral contraception are all predisposing factors for this condition. So there are many causes of thrombosis. You have some of the importance are the oral contraceptive, surgery, okay, infections, very important, catheterization, vasculitis, so you have to recall them. Okay, what left is how to treat thrombosis. Actually, treatment of thrombosis depends on the underlying cause, okay, but usually heparin is very important to treat thrombosis. Sometimes we need longer drug like warfarin. Okay, warfarin may be used in treatment of thrombosis. Okay, if we have a life-threatening thrombosis, we may initiate treatment of fibrinolytic agents. Okay, we may give fibrinolytic agents like plasminogen activators. Okay, in newborns, the inherited deficiency syndromes may be present as emergencies, and these emergencies necessitate the replacement therapy with plasma, antithrombin 3, okay, and protein C. Okay, so in neonates with deficiency in those factors, the plasma, antithrombin 3, the protein C, as I told you, you can replace them. Okay, so heparin, warfarin, okay, replacement therapy if we have a neonate that are in need. Fibrinolytic agents sometimes are given, so this is treatment of thrombosis in general. And by this I end this very long subject, the hemostatic disorders. I started with the definition, the physiology of hemostatic disorders, then I moved to the types, the primary hemostasis disorders, the platelets disorder, the number and the function disorders of the platelets. Then I moved to the coagulation disorders, the hemophilia, the von Willebrand disease, the thrombosis, the DIC, and this is the end of the story. It was very interesting, very nice, and very hard to explain such thing. I hope it was helpful. Thank you very much for watching. See you in other video in other pediatrics topic. Okay, thank you very much.